This is pretty much the final one in terms of, abdo, cardio, respir, all follow a similar pattern. And then from next week, Jack's going to do neuro, and I think the last week is sort of open to whatever you guys want. So we'll do neuro, cranial nerves, and then the final week we'll take a vote as to what you guys want to do. Okay, cool. So let's get started. So rest. We've been through. Hands up, who was here last week? Most people. Okay, and the week before, same people. Yeah. So we've been through the whole introduction, gaining consent, etc., etc., etc. So I won't repeat it. But what I thought, because we looked at this week's feedback, and a lot of people were like, let's do more demos or whatever. So what we would like to do is get a volunteer. Is anyone? All you have to do is your intro blurb up until looking at the face. Because rest, I'll tell you now before we get onto it, follows the exact same pattern. Hands, arm, neck, face. Exactly the same as cardio. Is there anyone who's brave enough to practice that? Yeah? Brilliant. Round of applause. Yeah. So Jack's going to be our presentation again. Okay, so May. Okay, nice to meet you. Okay, guys, so this is May. She's bravely volunteered to do an intro. So I'll be the examiner, Jack will be the patient, and just treat it exactly as you would for the examination. Say everything you would say, get Jack in the right position, in the position you'd like him to, and then I'll just keep going as pretend it's a cardio exam because it's exactly the same, and I'll stop you when I think it's appropriate. Okay, sound good? Okay, off you go. Sorry, teacher. Hello? Does this work? Hello? 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 There you go. And then come around this side. Just do every examination from the right side of the patient.
Which will just involve me having a look at your hands, your face, your chest, and having a listen.
Yeah,
okay?
that's fine.
Thank you. Can I just confirm your name and date of birth?
Yeah, it's Jack Fulton, that's 3rd of 5th, 1990.
Okay, I'll just double check with your wrist now. Okay, thank you. I'll just, would it be okay if I talk?
Yeah.
Right, thank you. So I'll just observe from end of bed, patient seem comfortable at rest and not in respiratory distress. Would it be okay if you remove your top?
Yes.
Are you okay lying down in this position?
Yeah, fine.
Not in pain? I don't see any obvious scars or any chest deformity. Okay. So just now have a look at your hands, please. Nice and warm palm juice.
Carry on.
Okay. So I'll do blood pressure and stuff. I'm just going to pull down your eyelid to check the pneumonia. Yeah. Can you open your mouth a bit and stick your tongue to the mouth? Can you look to the left? Thank you.
Brilliant, and stop there. Well done. No, you're really good. Yeah, excellent. It's not easy when you've got this many people watching you, so it won't be like that in your OSCE. Really well done. I don't think there was any steps that you missed. Do you guys talk through your OSCEs, right?
Mm-hmm.
Right, fine. Okay. Did you ask him if he was in any pain? She did?
Yeah, I definitely are, but say it like explicitly.
Make sure it's very, very clear, because I mean, if I missed it now, and you know your examiner may easily miss it, just specifically say, "Are you in any pain?" Before I begin this examination. The only other thing I'd say is when you're pulling down on his eyelids, get him to do it. It's a bit sort of uncomfortable and a bit invasive, like when you're touching someone's face.
So I've got like some consultant who told me like to just do it rather than asking. Some consultant, I don't know.
The thing with OSCEs is it's not really how you'd actually do it. It's about like putting a show on and just being as patient-centered as you possibly can be. And just that way you're not going to accidentally poke them in the eye or anything, because they're just going to go.
And I mean, okay, fine, he's a consultant, or he or she's a consultant, and you know they've been doing it for much longer. But I'd argue just reaching in and grabbing someone's eye is pretty uncomfortable, really weird. So always ask permission for everything you do. Explain everything explicitly, because if the examiner's not watching, at least they're listening and they can hear what you're saying. But yeah, and if you're going to speak, then when you speak, look at your examiner, and otherwise look at the patient. But honestly, I think like very, very good. You know, your exam standard at the moment. So from now until then, it's just fine tuning, looking slick, and all those little fine touches. But very well done. Thank you for being brave and coming up. Good. So so introduce ourselves, gain consent from the patient, ask if there's any pain, expose the patient and position. So again, we need the whole chest exposed. So just ask them to remove their shirt and put them at 45 degrees for this examination, okay? And then you wash your hands. And even though you gel your hands on the way in, you still need to wash your hands before the exam. Because gelling your hands is going from one clinical area to another. But you know, before you touch the patient, there may be a mark specific for washing your hands. I mean, I would say soap and water is essential. Okay? Gelling your hands between stations is very good and it shows you're aware, but it's definitely a mark for it on the mark sheet.
Will there be like a sink?
Yeah, definitely. It'll be in a hospital in a clinical room. In a clinic room, sorry. They'll hire out like an outpatient for the afternoon and do it there. Okay? Cool. So we've done that. Good. So again, like all examinations, it starts inspection, palpation, percussion, and auscultation. Those are the four main parts of any examination. So, what kind of things are we looking for around the bedside in a respiratory examination? Inhalers, very good. Anything else? Oxygen. Chest drains. A nebulizer, very good.
Heat flow meter.
Very good.
Speech input.
Excellent. Salbutamol inhaler, yeah, we had inhalers, very good. Anything else?
Just a point, if you find a sputum pot on the side, what are you going to do with it when you see it?
Look inside it.
Yeah, make sure you have a look inside it. Don't just be like, there's a sputum pot there. Go and open it up and have a look.
Very good. Cool. Yeah, I think you guys got most of them. So peak flow, oxygen, nasal cannula, could be through a mask, could be with a CPAP mask, which is a lot tighter, and that gives you an indication of how sick the patient is by how much oxygen they're requiring. Sputum pot, as Jack said, you've got to have a look inside, and inhalers. One thing, a big thing, is a packet of cigarettes. You know, that the patients still smoke. It's not easy to, just because you're sick doesn't mean they quit instantly. We had a patient on the ward who had really bad COPD, wasn't getting better, but kept leaving the ward every hour or so for a cigarette, and the consultant just called him and was like, please stop smoking. And he's like, I know, but I just can't. So they may well have cigarettes by the bedside. So, getting an idea early on. So when you look at the patient, it will give you, like we said before, with the abdo exam, with the cardio exam, this is the part where you're starting to narrow down your diagnosis already. And you're starting to think, okay, it's one of two, so that now I know when I listen, that's where I'm going to figure it out. Okay? So, if you saw a patient that looked like this, how would you describe this appearance? Sorry? Cachectic, very good. So what kind of diagnoses are you thinking about? Malignancy, excellent. A lot of elderly people look like this in general. It's a sign, they can be just generally frail as well, but when you're that emaciated and skinny, cachexia and malignancy might be going through your head, okay? What about this? Yeah. So for what operation? What operation has this person had? Not a lobotomy, no. A lobectomy. Close, similar words, but yeah, a lobectomy. So one form of treatment for smaller cancers that haven't spread, and they've maybe been shrunk with chemoradiotherapy, and then they can remove the cancer. Okay. Anyone watch Breaking Bad? Yeah. So he had a lobectomy scar. What about if a patient looked like that? Sorry? Chemotherapy, yeah, hair loss, signs of ongoing treatment, okay? All of these clues you're picking up just by looking at the patient, okay? What about this? I mean, she looks pretty healthy, but what if your patient was sat up in bed like this?
Using the accessory muscles.
Sorry?
They're using the accessory muscles.
Yeah, accessory muscles, and what sort of, when you're really tired, and you just go on a run, you prop yourself up like this, what are you doing?
Fixing your muscles.
Fixing your muscles, yeah, so it's called splinting. So it makes breathing a lot easier, and if someone is like that who hasn't just gone for a run, and they're sat up in bed, it's a classic sign of COPD patients. Okay, they actually won't tolerate lying flat if they're really unwell. They won't be able, you won't have someone like this in your exam, but maybe they might be able to tolerate it in little bits. So when you come into the room and they're at their most comfortable position before you got them in position, they might actually be sat up like this. Okay, I had a patient who literally couldn't lie flat, and she was just like this, sat up in bed. Okay. What about if the patient looked like this? I love the little whisper. Everyone knows, but no one's Cushing's, yeah? I think everyone said it. Cushing syndrome, okay? And what would you infer from that presentation? What's that got to do with the respiratory examination? What causes Cushing's?
Ectopic ACTH.
Yes. Yeah, very good actually. But what's more common? Yeah, who said that? Who said iatrogenic? Yeah, very good. So it could be most commonly a side effect of steroid therapy. Okay, and you use steroids in a lot of respiratory conditions to decrease the inflammation, and patients will be on chronic long-term steroid therapy and literally look like a lemon on sticks. Like they're just a little round ball, skinny legs, bruised all over, and their face is really round. Okay, but yeah, ectopic ACTH from tumours is a very good point actually, but unlikely in uroscopy, but well done. Okay, deformity. So what's this called? Pectus excavatum, very good. And this one? Carinatum. And what's this shape of the chest? Barrel chest. What's it commonly? COPD. Excellent. So just by standing at the end of the bed, these will affect your respiratory function, aren't necessarily associated with pathology, but people who have this kind of deformity might have difficulty in breathing. But if they look like this, if they've got a barrel chest, really round, and they look like this, You know, I walked into my finals and my patient genuinely looked like this. And so I was like, okay, I've got a good idea of what they're on. I just now need to listen to the chest. When I heard nothing on the chest, I was fairly confident in saying this patient had COPD. So in the end, I had time to spare. So I got the patient to stand up and test for proximal myopathy, and the patient was like, and the examiner was like, what are you doing there? What's that got to do? But in Cushing's syndrome, you can get proximal myopathy. So I said, well, the patient appears Cushingoid, and he looked at me and went, and he just like couldn't believe that, you know, that if someone had actually said that. But if you've got, you know, if they look that barn door and you say it, you will look awesome. Okay? Cool. So like we said, every examination starts with the hands, moves up to the neck, to the face, and back down. Okay? So no changes there. So what we've been through this. What's this? Clubbing. Very good. And toe clubbing, as we said before. What are some of the causes, the respiratory causes of clubbing?
Cancer.
Yes.
Fibrosis.
Sorry?
Fibrosis.
Cystic fibrosis, yeah.
Bronchiectasis.
Sorry?
Bronchiectasis.
Bronchiectasis.
Empyema.
Yes. Yes. And TB. Okay? So we test it formally. I think that actually, now that I remember, that's something I think you forgot, May, just to test for clubbing. Because in the cardiac causes of clubbing are very rare. So you'll probably be excused for not formally testing it like that. But abdominal causes and respiratory causes, there's loads. And you're likely, you may well get someone who's clubbed in your OSCE. So I would formally test it every time. Just make it a routine of part of checking the hands, okay? What's this? Tar staining of the hands as a sign of someone who... Very good. And this is it's impossible to put in a picture, but what is this? No? A tremor. Very good. So if you walk into your respiratory exam and someone has a tremor, what could that be? Very good. So an iatrogenic cause, so it'd be a side effect of medications, likely to be salbutamol, specifically in a respiratory examination. Okay. Cool. Someone very rightly said last week that Pancoast tumours should be considered. Less so in a cardiovascular examination, but very appropriate to consider in a respiratory examination. Okay, so Pancoast tumour is an apical lung tumour up here, affects the apices of the lungs. Okay, and when you're looking at the hands, a Pancoast tumour will invade upwards. Okay, and your brachial plexus, the lower border, the lower chords of the brachial plexus can be T1 and C8. Okay, and they predominantly make up your ulnar nerve. Okay, so when you're looking at muscle wasting in the hands, yes, the ulnar nerve supplies the small muscles of the hands, but in older people, you know, if you think about older people's hands, they're already pretty wasted, pretty, you know, you can see all the tendons and everything, and it's hard to tell, have they got wasting of the muscles in the hands or not? The best way to see if there's an ulnar nerve damage or any deficit, okay, is by looking at this first web space here, between your thumb and your first finger, okay? Because if everyone puts their hand out like this, okay, and you move your first finger out, okay, and feel over here, put it in and out, like that. Can you feel a muscle contracting? Yeah? That's your first dorsal interossei, okay? That abducts your first finger. And secondly, your adductor pollicis, which brings your thumb down like this, okay? If you feel on this side, you might be able to feel it contracting. Those two muscles make up a fat wedge of muscle, okay? So these small muscles in between the fingers and things, they might be difficult to assess in older people. But older people will definitely have this nice chunk of muscle there. And can you see here, in this picture, the difference between this side and this side? Can everyone see that? There's a definite dip there. Yeah? Can anyone not see it? Cool. So that will give you, if you're looking for muscle wasting in the hands, that is the best place to look for the ulnar nerve lesions, and specifically with the pancreas tumour, it's most likely to be the lower brachial plexus. Okay? Cool. So, as we said, now say, can I start by looking at your hands? Can you place them in mine? I'm a big fan of touching the patient as little as possible, okay? Getting them to do the work, it looks slicker, alright? And just making them sign with your fingers. So you ask them to place their hands, and then ask them to turn them over. Again, we want to do there's one, I think, but you didn't know because it was, I told you to do it as if it was a cardio exam, and that was very good. But there's something to consider now in a respiratory exam that we considered in the abdominal examination, but it's a different pathology and it's got a different name. Okay? So, in the abdo exam, we popped our hands out, cocked a wrist back like Superman, and we were looking for a flick like that, a flap, yeah? And that was asterixis, sign of decompensated liver disease. In a Resp exam, it looks exactly the same. There will be a beat like this, but it's a sign in a respiratory examination, if you're thinking of that along those lines, of a CO2 retention flap. So someone with severe COPD, or an infective exacerbation, for example, of COPD, causing an increased CO2 retention, you're likely to find it in those patients. Okay? Looks exactly the same, but don't make sure you remember to look for it. Alright? Cool. Something we haven't done formally in other examinations, but is a big sign of how well a patient's doing, generally speaking, is the respirator. And in a Resp exam, it's a must. You have to check for it, okay? So like a driving test, what I would do, when you tell someone I'm just going to look at your breathing, they automatically become very conscious of their breathing. So they're like, okay. And it's just like that, you know, you affect the way they're breathing if they know you're looking at how they're breathing, okay? So I just take their hand. So the way I do is I pop your hands in mine, sir. Have a look at the hands, have a look at the nails. Okay, and turn your hands over for me. Good. Okay, make an M sign with your fingers. Very good. Now pop your hands out like this, like Superman, and cock your wrist back. Okay, I'm just going to take your pulse now when you do that, okay? 15 seconds, feeling the pulse, checking for a flap for 30 seconds. Okay? And then once I've done 15 seconds, because I have to do this for 30 anyway, so the first 15 seconds I'm looking here. Second 15 seconds, I just look down at the chest. Okay? So that's the easiest way to do it. Just make sure, if the examiner comes, because sometimes the examiners are really annoying and they'll just like stand here. And they'll just like watch you, and it's really off-putting. But it's a good chance for you to show them that, you know what you're doing. So just, not with your eyes, not whatever, literally turn your whole body and just look at their chest. Because the patient, you haven't told the patient you're looking at their breathing, they won't change their respiratory rate. You've already told them you're looking at them, but it lets the examiner know, I'm looking at his rest rate now, okay? And of course, presenting it at the end, the number at the end, indicates that you looked for it, but there'll be definitely a mark for looking at and checking explicitly the rest rate, especially in a Resp exam, okay? Cool. And at this point, I would like to take the patient's blood pressure. Would you like me to do so, as we've done in every exam before, okay? Now, as you said, can we look at the eyes? Some of the things in the face, what are we looking at or looking for in a respiratory examination? Central cyanosis, very good. Sorry? A Horner's? Why would you get a Horner's? Very good. So, we'll come on to that in a minute, but a pancreas tumour again can invade the sympathetic chain in your neck. And it will cause an ipsilateral, meaning the same side, it will cause a Horner's syndrome. Okay, does anyone know what a Horner's syndrome is? Sorry? Yes, so that's one aspect, very good. Very good. Okay, good. Well done, mate. Ptosis, yep.
Bloodshot conjunctiva.
Not specifically. Is this part of Horner's still, or generally speaking? I don't know. There's four aspects that we'll come on to. I mean, maybe that is, but it's not something I've heard before. Maybe if you've read it somewhere, but I don't think so. Anything else in the face? We'll come on to Horner's in a minute. Anything else in the face that you're looking for in the breast exam? So enophthalmos is the last one of Horner's, very good. No? Okay, so conjunctival pallor, all three examinations, conjunctival pallor, anemia. If you're anemic, you might be short of breath. Very applicable to a respiratory examination, yeah? And then, as we said again, so a pancreas tumor can invade now, what you're looking for is the sympathetic chain, okay, causing an ipsilateral, same side, Horner syndrome. And the four features are meiosis, ptosis, enophthalmos, and hydrosis. They sort of, because they rhyme, and I don't know, I find that they roll off the tongue. But what it is small pupils, meiosis, ptosis, so drooping eyelid, okay, enophthalmos, so sunken eyes or apparent sunken eyes, and anhydrosis, so reduced sweating on that side of the face. That's what those four things mean, okay? And you can sort of work them out because if your sympathetic chain is active and the fight or flight response, your eyes dilate because you want to get as much light in as possible. If you look startled, your eyelids go up. So it's essentially the opposite. So all those things are knocked out. So you get your drooping eyelid, your small pupil, your sunken eye, and you reduce sweating. Okay, so that's another thing you're looking for in the face. And does anyone know what different sized pupils are called? The word for it? Anisocoria. Okay, just FYI. So in the mouth, this was central cyanosis, but something no one said was oral candidiasis. Why is oral candidiasis a sign of the sign that you look for in a respiratory examination?
Immunosuppression.
In what way?
You could be looking at TB if they're already immunosuppressed.
Okay. That's fine. Sorry? Steroid inhalers is the main one. That's what I'd be worried about because if people aren't rinsing their mouth out after steroid inhaler use, you can get it's a risk factor for developing oral candidiasis or thrush. Okay, so when you ask them to stick their tongue out, you're looking for that whiteness over the tongue. Cool. Any questions so far? No? It's exactly the same. The Resp exam is the longest exam. Cardio is the shortest, but there's sort of a lot of pathology. In my opinion, Resp is the easiest to understand. When you're examining, when you're listening, whatever, it's the easiest to understand because the signs are all very different. But it's definitely the longest exam. So this is one you really want to get slick at because you don't have any time to waste. Alright? So up until now, it's the same as every other examination, but the signs you're looking for are different. So it's important to consider them. Okay, and what is that?
Polyp.
Sorry?
Polyp.
Very good. A nasal polyp. A lot of people, it might not even be on your mark scheme, but it's good to look for because it shows that you're aware of things, you know what you're looking for in this exam. What disease might give you nasal polyps? No? So cystic fibrosis can give you nasal polyps. Okay? Just a little thing to make you look slick, to make you look like you know what you're doing, just a little bit extra. Okay? Yes?
How would you do that in the OSCE? Because we wouldn't have one of those.
No, so just with a pen torch. Ask them to lean back with a pen torch. You may be unlikely to see it, but you're just showing them that you know that you're looking for it, or you want them to know that you're looking for it. And finally, on the neck, the JVP, okay, which May did very well. And if there's a bedside light, I'd bring it round and have a good look at the neck, okay? Good. As a sign of right heart strain, specifically in a Resp exam, you're looking at pulmonary hypertension, okay, causing your right heart strain and therefore leading to an elevated JVP. Alright? So whenever you're looking for these signs, make sure you know why you're looking for them in each of the examinations. Yeah? Because you don't want to say, like, I'm looking for, opening the mouth, oh, what are you looking for? Oh, angular stomatitis, ulcers, yeah, but this is a respiratory examination. Yeah? You don't want to say that. You want to be telling them, the steps are all the same, but what you're looking for is different. So you've got to make sure you know what you're looking for in each of the different pathologies, each of the different examinations. Alright? Cool. This part is new. So, the cricoid cartilage, can everyone feel their neck? Okay. Can you feel the top of your sternum? Yeah? That little dip, okay, in your manubrium. Put 2 fingers above it, like this. Yeah? And then just run it up a little bit. Can you feel this cricoid cartilage? Okay, you can feel your Adam's apple. And then move your hand, roll your hand down, and there's another little bump. Can everyone feel that cricoid cartilage? Yes or no? Yeah? So when you're feeling that, you want to measure the distance between that and your sternum. So it's about 3 fingers. Does that fit with everyone? No? Yes? No? Blank looks. Yeah? It's about 3 fingers, okay? And it's significant, so this is something new to the respiratory examination. So the way I do it, Jack, if you can mind back. All you say is, okay, so now I just need to feel your windpipe. It might be a little bit uncomfortable. Let me know if it's painful at all, or you want me to stop. Because it is a bit uncomfortable. You're pressing on someone's neck, okay? You feel the sternal notch, manubrium, and then run your finger up for the cricoid cartilage, and then measure how many fingers are there, and then I'll come to it in a minute, but you place your your index and ring finger on either clavicle, okay, and then with your middle finger, place it on the middle of the trachea. And you make sure that middle finger is equidistant between the ring and the index finger, okay? So that is a test for tracheal deviation, and the first one is the cricosternal distance, okay? Or cricosternal distance. That is significant. The cricosternal distance is significant because whenever you talk about COPD and signs of a hyperinflated chest, okay, there's actually 3 signs that are actually pathological or imply a hyperinflated chest. Okay, a barrel chest, just looking big, whatever, isn't actually a formal way of assessing hyperinflation. 3 ways are a decreased cricosternal angle, loss of cardiac dullness, and a palpable liver edge. In my opinion, there won't be a mark for palpable liver edge on your Resp OSCE mark sheet, okay? But checking for it, again, will make you look awesome, okay? So, what it is the hyperinflated, the COPD, they're all like this, and they go, it's really shallow breathing, okay? So you sometimes won't be able to get 3 fingers between their cricoid cartilage and that sternum. Maybe 2, maybe even 1. Your chest will be really drawn up, your trachea will be pulled down, okay? So that's actually what you're checking for. And then loss of cardiac dullness, when you come to percuss over the chest, you'll notice that it's slightly duller over where the heart is, okay? But if it's hyperinflated, you get more air in the lungs and you won't notice the difference in dullness, okay? These are very subtle signs, but again, if you're checking for them and you say them, if the patient has clearly got COPD and you say, but there was no signs of hyperinflation, namely no reduced cricosternal distance, no loss of cardiac dullness, and if you actually tested for it, no palpable liver edge, it will make you look really slick, okay? So that's something to work into your presentation. The second thing I tested for was tracheal deviation, okay? What's this? Sorry? What kind of pneumothorax? A tension pneumothorax. This is one of those sort of make or break x-rays that you might get in finals. They'll be like, if you're not doing well, they'll be like, they'll put one of these up and they go, what is this? And if you still can't get it, you fail, okay? It's like when you see one of those, you have to get it. But if you look over here, so the air is rushed in, there's a one-way valve that's been created, so air can only get in, but it can't escape. So essentially it's just pushing everything all the way over, because it keeps filling. Every breath they take, more air rushes into that side, everything moves over, collapses the lung, pushes the mediastinum over, pushes the trachea. Can you see this? This trachea, yeah? Massively deviated. all of this, everything's just been pushed over to this side. Yeah? So when you put your two fingers on the two heads of the clavicle, yeah, where they attack the sternoclavicular joint, where the clavicle meets the sternum, but that's fixed, yeah? Your bones aren't going to change in distance. So you put your two fingers on your index and your ring finger on those, and then you put your middle finger on where the trachea is. And if it's way over to like this side, you've got some deviation, and likewise that side. Okay, but if it's in between, that's what you're looking for. You almost certainly won't get someone with a deviated trachea and no, you definitely won't get tension pneumothorax, but you probably won't get a deviated trachea, but it's something you have to check for, okay? So now we're into the new things for respiratory examination that you're checking for. So your cricosternal angle, distance, cricosternal distance, and a deviated trachea. With tracheal deviation as well, something to bear in mind, it's probably more for EMQs, but when air rushes in, the way to think about it is like this, okay? If air rushes in, it'll push everything over to the other side, yeah? So your trachea will be deviated away from the pneumothorax. Air's rushing in, pushing everything, trachea's going this way. If you get collapse and fibrosis and consolidation, it's like grabbing lung and shrinking down, okay? So it grabs trachea and pulls it in with it. So the trachea deviates towards collapse and consolidation, but away from air that's rushing in. Does that make sense? Yeah? So it's good to think about, if you think, oh, which way should the trachea be deviated? Think of it this way. Air is not grabbing it, it's pushing trachea. Consolidation, fibrosis, and collapse is pulling trachea. Okay? Cool. And that's just a diagram of how to test what I did on Jack, if anyone can see. Cool. Again, I like asking the patient to put their hands up like a chicken and make sure you get a good look at the chest, because lobectomy scars are right round the back. Okay, so if they're like this, you probably won't see it. Okay, you need to get them to put their hands right up, really have a good look down here. And at the back as well, for chest drains in situ. Or bandages, as I'll come to show you in a second. You may get like a little dressing over a drain site where it was, and now it's been removed. Okay, so with a Resp exam, I would advise you to start with the back. Okay, the lungs reach down to T10. Yeah, T10 at the back, but only T6 at the front. So there's much more lung at the back to listen to, and most of your pathology will be at the bases. Yeah? So get them up, listen to that back first, because you want to be smart with your examination. You don't have that much time in the exam, so you want to be like, okay, where's the pathology likely to be? At the back, at the bases. Get them up, listen to the bases first, then move up. Yeah? So that's where you want to start your examination. So, when you've got them up, kindness is key. So what I always say is, so you've got them lying at 45, and what you'd say is, okay, so what I'd like to do is start by listening to your back first, if I may. So can I ask you to just lean forward for me? Good. And it's a bit uncomfortable like this, so what you do is you take the pillow, and you say, if you just pop your hands around this pillow for me. They think, well, that you are being nice, but you've been very nice. But what it also does is moves the scapula out of the way. Okay, so you're not listening over scapula. Moves it out of the way, you've got more space to listen to the back. Okay, and they think, oh, that was really nice. It's really uncomfortable, but now I'm quite comfortable hugging this pillow. It's great. I'll give them a better mark. Okay? So then you have a good look at the back again. All right, inspect everything that you do. No lobectomy scars, no deformity. So, next point, palpation. Palpation in a Resp exam, you're testing for the expansion. Okay? So, the way to do this is you say, sorry if my hands are cold, so what I'd like you to do is take a deep breath in, and all the way out, okay, and hold it there. I'm just going to place my hands on your back, and breathe in, and out. Okay, Jack, can you turn around for me, so everyone can see? So what you're doing is you're getting them to breathe in, and then all the way out, okay, and then you really wrap your hands around, but not your thumbs, just your fingers, okay? So can you guys see over there? Breathe in, Jack, all the way out. really get round, okay, and make sure your thumb, they're at the same level and they come to the midline. They don't have to be touching, because in the bigger guys you probably won't get your hands all the way around, especially smaller girls. And can you see him breathe in and out? And breathe in, Joe? What you're looking for is to see your thumbs moving apart equally. Okay? I'll fake it, obviously, because he doesn't have any pathology. But if you only get one hand moving up, only one thumb moving up, okay, that's decreased expansion on the right side. My thumb isn't moving as much. Okay? And that can be a sign of consolidation, collapse, effusions, anything affecting that side of the lung. Air isn't going to be filling it as much, so that it doesn't inflate as much. Does that make sense? Yeah? You don't want, what you're not doing is your thumbs are on the chest. Okay? You want your thumbs to be free, so you really wrap around so that any breathing he does affects your whole hand, and your thumbs are off the back, and you're seeing them move apart. And what you do is you test it at 2 locations. So breathe out, wrap, and breathe in for me. Okay, and again, and up. So top and bottom. Okay, 2 locations always. Cool. Does that make sense to everyone? Yeah?
With that, especially like girls with little hands, make sure you just get like a big grip all the way around and really pull it all together, because otherwise you're just resting your hands on it doing nothing.
Obviously that didn't apply to me. I'm a little girl, but it's fine. Cool. So that's palpation. Next step of an examination is percussion. Yeah? So, has everyone been practicing percussion? What makes percussion louder? I'll do it this way. Sorry? The harder you press with that bottom hand. Okay, so lean forward. And what you don't want to be doing in a Resp Exam, very good, whoever's percussing the table. You don't want to be percussing over a rib. Yeah? Doesn't make sense because it's going to be dull. You're percussing bone. So what you want to make sure is you feel for spaces between the ribs. Okay? Okay? And you want to test for 3 spots down bilaterally. So you percuss at the same level, and what you're doing is comparing either side. Okay? Then move down. And hopefully it should be resonant. Okay? So I pick 3 spots, and then the axilla. Always the axilla. Never forget the axilla in a Resp Exam. And this side. Once is fine. Okay? So 1, 2, 3, and the axilla.
Sorry, for the percussion, how low do you go? So you said the lungs at T10.
Yeah.
And then you get fluid and stuff underneath, so you go lower than the lungs?
Underneath, well, you can go up until the bottom of the rib cage.
Okay.
But,
Going below the lung, you're not going to tell the difference between air and fluid anyway, because it's just going to be fluid or not fluid, and then you're trying to tell the difference between stony dull and dull, which you never can.
but it's just you're just getting a rough idea of the 3 zones. So top, middle, and lower. Not lobes, zones. Okay. Which brings me nicely onto, if you lean the patient forward and they have that, yeah, they may not even have a drain, they might just have a bandage, okay? But that is beautiful, because you see it and go, thank you, they've had a drain, okay? They've had a drain. In your OSCE, it's almost certainly going to be an effusion, okay? So they'll have had a big effusion, but the reason they put them in your OSCE is because they still have a small effusion, but they're not unwell. Okay? So, when you're percussing, and you come to the area over the dressing, and it's dull, okay, you know they've had a pleural effusion, and you know that dullness is due to fluid, because you're only going to put the drain in for air or fluid, and if it's dull, it was fluid. And a pleural effusion, you may have been told in your EMQs and stuff, is reported as stony dull, yeah? And I don't know about you, but there's no way anyone can differentiate between dull and stony dull. Like, it's just stupid, okay? But it just means really dull. But if you say it in the exam, because every other sign points to a pleural effusion, and you say it was stony dull to percussion, then you look amazing, because they're like, well, how can you tell the difference? Well, and you say everything else points to a pleural effusion, and in my experience of percussing loads of pleural effusions in the ward, I know what stony dull sounds like, okay? And they can't argue with it, because it's an effusion, and therefore it sounds stony dull, all right? You can't tell, but everything else points to pleural effusion, so you add that little bit extra, and you sound amazing, okay? It's not going to be anything else. If it's resonant, then it may be a pneumothorax, okay? So you say it's hyperresonant. Lungs are normally resonant because they're full of air. Hyperresonant is when it's just air and there's no lung tissue in that area because it's collapsed. And there's air in the pleural space. Okay? And as I said, don't forget the axilla. Auscultation. So again, you're going to listen over the same 3 areas that you percussed and the axilla. Simple. You have to do that deliberately as well. Pick those same 3 areas. There's no point in percussing over an area and then listening over somewhere else because you can't add the 2 together, yeah? Doesn't make any sense. So just percuss top, middle, lower, and then auscultate over the same sides. And what you want to do is be smart with your stethoscope. So lean forward, Jack. So when you're listening, okay, start at the bases, okay? And deep breath in through your open mouth for me, sir. And what you're doing is you're comparing like for like, okay? So don't listen to inspiration on this side. Breathe in, Jack. And then expiration on this side. That's silly. So inspiration. And move over for inspiration. Yeah? You want to check if crackles are heard on inspiration or expiration. Yeah? So you want to compare both sides. There's no point in listening. You say he had inspiratory crackles on the right, but I only listened to expiration on the left. Yeah? You're not just listening generally. Make sure you're comparing what am I hearing on the breathing in to the breathing in on the other side, and the breathing out on the right to the breathing out on the left. Yeah. So you're moving your stethoscope quickly across, back and forth, back and forth. Just let me get a good look, a good listen. Breathe in and out, and again, and again, and again. Yeah. Okay. Cool. So now you're trying to figure out what you're listening to. Okay. And I won't do it so I can hear you guys, but what I say is deep breaths in and out through your open mouth. Okay? So, deep breath in for me, and out, and again, and again. So, middle zone, and again, and then the top, and again. Thank you very much. So, even Jack's a little bit tired, okay, and he's a healthy young man. So, bear in mind, so my next point, before I come on to breath sounds, way ahead, wherever it is, anyway, yeah, take a break. When you come to do the front, make sure you give patients a little break, because if they're a little old lady and they're already short of breath on oxygen, you're telling them to go, it really tires them out. So showing them that you care, you're aware of the patient in front of you is really important, okay? You're putting them through a lot, up and down, tapping on the back, getting to breathe out, in and out. It's really tiring, so make sure you offer them a break, okay? So different breath sounds. So vesicular sounds, yeah, this is where this is the key part, where you're really trying to listen, trying to figure out what pathology is going on. So has everyone got their stethoscope with them? Yeah? Anyone who does, get it out. Okay? Pop it in. And now listen to yourself breathing. Just over your lungs. Okay, take a deep breath in and out. And again and out. Okay? Pop them out. Do you notice that inspiration is louder than expiration? Yeah? Loud inspiratory sound and it fades on expiration. That's normal. Bronchial breathing, here, it's more like this really. is where you get the inspiratory phase is just as loud as the expiratory phase. And it occurs when you're listening to the larger airways, because in lungs that have collapsed. Okay, so if you get bronchial breathing, what's called bronchial breathing, over an area of dullness to percussion, you might be considering, you know, consolidation, they might have a pneumonia, that sort of thing. The way to listen for practice bronchial breathing, very good, is listen over your trachea. Pop your steth over your trachea. Yeah? Take a deep breath in. Can everyone hear the difference? Do you hear the difference? Yeah? So just like last week when we practiced heart murmurs on our hands, you can practice listening to bronchial breathing. Okay? The other sounds that you might hear are wheeze in an asthmatic and some COPD patients, and then crackles. Okay? Crackles, fine end inspiratory crackles. So right at the end of inspiration, you're just hearing those last few little alveoli popping open. Okay, a classic of pulmonary fibrosis. All right? And that sounds exactly like walking on fresh snow. I don't know if you sort of, everyone's walked on fresh snow, that sort of crunch under your feet, yeah? Does everyone imagine that? That's exactly what it sounds like, okay? Whereas coarse expiratory crackles are classic of bronchiectasis. You may also get them in pulmonary edema. They sound wet, and they're loud, and they're harsh, and they sound, you know, loads of different sounds alveoli popping open, okay? It's really wet, and they may clear on coughing. So what you do is if you hear it in the exam, you pop your steth on and go, okay, I can hear that. Can you give me a cough, sir? They might go away. They do, you know, they're coarse crackles, and they clear on coughing, which is something to say. And that's mucus and fluid buildup, okay? And they sound exactly like tearing open Velcro. So when when you couldn't, think back to when you couldn't tie your shoelaces and you had old school Velcro shoes, that sound when you're ripping open the Velcro, that's coarse crackles, okay? So if you compare the two sounds, the best way to do it is go onto the wards and listen, because fine end inspiratory crackles can be hard to hear if you're not sure what you're looking for or if you haven't practiced, okay? Cool. So the breath sounds as well, you want to also listen for how loud they are and if they're equal on both sides. In a pneumothorax, you won't hear any breath sounds on the right. Okay? And areas of collapse, consolidation, you'll hear reduced breath sounds. Effusion, reduced breath sounds. Okay? Makes sense, because there's something occupying that lung space, there's less air going to that part of the lung. Yeah? Reduced. In a pneumothorax, it's just air that's taken up that space. Lung is collapsed, you will hear no breath sounds on that side. You may hear breath sounds transmitted from the other side, and they'll be very reduced, but there's a definite difference. That's why you've got to move your steth over across loads of times, which is why, because there's a lot to do in this exam, you've got to be savvy with your time, okay? Cool. Now, the last thing you want to check for is vocal fremitus, okay? And you can do this in one of two ways. You can listen with your stethoscope, and you're trying to get the patient to make a low-pitched sound. So you say ask them to say 99, all right? That's not that low. There's loads of other, there's like other words you can get them to say, like toy boy or something like that, which is like a bit weird. But so just stick with 99. But it originally started by someone saying German 99, okay? And that was just translated because that's a much lower sound, lower pitched sound. But then it's translated into English into 99. But it still works, okay? So the way I do it, or with your step, or you can do it with tactile vocal fremitus. And I'll just demonstrate both to you now, okay? So I've listened over the three areas, yeah, left and right, and then I say, okay, sir, so now I'm going to ask you to say 99 every time I place my stethoscope on your back, okay?
99.
And again.
99.
Easy, okay? And what you're listening for is the difference in both sounds, or if it's increased or decreased. Alternatively, you can do tactile vocal fermenters, and that goes like this. Okay, so I'm going to place my hands on your back, and what I'd like you to do is say 99 every time I do. Okay, turn around. And what you do, you can look super slick, okay, by placing both hands on at the same time. Some people go 99. But what looks really slick, because what you're doing is comparing both sides, right? And you're trying to feel the vibrations of his speech transmitted through to your hands. So you can say 99 for me. 99. And again. 99. And again. 99. Okay? And it looks slick because you're comparing both sides, so you're feeling. In my opinion, it's really hard to feel the vibrations through your hands. Very subtle. So I would do vocal fermenters with my stethoscope. It's much easier, it's much clearer. Don't do both. Do whatever you feel more comfortable with, more confident with, feeling that you're going to pick up the signs. But don't do both, because it's testing the exact same thing. Alright? And what you're doing is testing how well sound is transmitting through the lungs. Okay? And sound transmits much better through solids than it does through air and liquids. Okay? So, everyone place your ear on the desk. Okay? Place your ear on the desk. And then, with your right hand or left hand, whatever, just tap on the desk. The bad friend over there. Do you hear that it's louder? Because you're hearing the sound transmit through a solid. Yeah? So you're hearing it like this, it's being transmitted through air to your ear. It's much louder when you put your ear on the desk, okay? So, same applies to your lungs, okay? When you get a low-pitched sound being made, you're breathing out, forcing the air through your lungs, okay? It transmits much better through consolidation. Consolidated lung, collapsed lung, okay? Therefore, because it's solid, your vocal fermenters will be louder. It'll be like 99, 99! And you'll hear a difference on either side, okay? And it really will be louder. I think, because so far with consolidation, which is more solid, and fluid in the fusion, so far there's reduced chest expansion on both sides, you've got dullness to percussion on both sides, and at this point you're not sure which one's which, right? But this is the determining factor, because through liquid, the sound is more poorly transferred. It doesn't transfer through the liquid to your stethoscope. So your vocal fermenters will be much more reduced. So you nailed it. You've got reduced expansion, it's dull to percussion, and the deciding factor, reduced vocal fermenters. That's why on the wards and stuff you actually have to test for it, because it does tell you the difference between each. Okay? And sometimes on X-ray they can look quite similar. Does that make sense to everyone? Yeah? Cool. So the reason for increased fermenters in consolidated lung is the fact that the sound waves are transmitted with less decay in a solid or a fluid medium than in a gaseous medium. Conversely, the reason for decreased fermenters in a pleural effusion or pneumothorax or any pathology separating the lung tissue itself from the body wall is that this increased space diminishes or prevents entirely sound transmission. Just essentially what I explained. Okay? Cool. So while you've got the patient leant forward, the whole point of this is to try and get you guys looking super slick at your examinations. Okay? So you don't want to get the patient up, down, okay? So they're leaning forward, so do everything for the back, and then move on to the front. Don't do your auscultation, percussion, etc. for the back, then the front, then I need to feel lymph nodes and whatever. So they're leaning forward, so I've felt for expansion, I've percussed, I've auscultated, and I've listened to vocal fermenters, and then you say, okay, so now I just need to feel for your lymph nodes, for the glands in your neck. Okay, let me know if it's painful or that's all. Feel the lymph nodes. Okay? And have you noticed any swelling at all in your back, or any pain? Okay, I'm just going to press lightly on the small of your back, okay? Press for 5 seconds, and you're checking for sacral edema. Okay? You've done everything on the back, now you can get the patient to lean back. Okay, it looks much slicker by asking the patient to do all the actions and moving them as little as possible. Cool. Sacral edema, lymphadenopathy. And now you do it all again on the front. That's why this exam is so long. Okay? You have to, yeah, that's why you have to save as much time as you can, because you're doing everything twice. You're doing a full examination twice, okay? Couple of points I'd say about the front. Once you've listened to the axilla once in the back, you don't need to do it on the front again. And most people, when percussing, percuss the first rib directly. Can everyone hear that? You don't have to use your finger, because there's already a bone there. Yeah? So just tap on both, and then only 2 more areas, okay? Easy, okay? And then when auscultating, a point about the front, use the bell, because it's small, and will fit in your supraclavicular fossa. Okay, so it just fits in there, and then that's how you listen to the, up here. Okay, and up here. You're listening to the apices of the lungs. That's how to listen to the top of your lungs. Okay, and then middle, middle, lower, lower. Okay, and then same with vocal fremators, top and bottom. Okay, sound good?
Yeah, sorry. On
Yeah.
the left, would you avoid the heart, or would you just go on top of it?
To percuss?
Yeah.
No, definitely percuss over it. Yeah, absolutely. Okay. Give your patients a break, as I said. So between sitting them forward and lying them back, just, so would you like to take a moment to catch your breath? Are you feeling short of breath? Would you like me to stop? All these little things make them aware that there's a human being in front of you, that you're touching, that you're moving. Yeah? Cool. With hyperinflated lungs as well, you can get displaced apex feet. Yeah? So make sure you listen, you feel for the apex. Just like we did in the cardiac exam, if it's displaced, you want to feel right round into the axilla and move round. Sorry, my hands are cold. And move them round, okay? And then again, count it down. 5th intercostal space. What's the clavicle lying over? First rib. Excellent. So the space immediately underneath the clavicle is your first intercostal space, and that way you can count down. You know where you are. Alternatively, use your sternal notch. Okay? At the level of the second costal cartilage. So the space underneath it immediately is your second intercostal space. Cool. Man, we are running over. Okay, so extras, you're looking for peripheral edema. Again, because if you've got pulmonary hypertension, right heart strain, right heart failure, fluid in the legs. Easy. Same with the sacral edema. Finishing off, thank you very much, sir. That completes my examination. Do you have any questions for me? And do you need any help getting changed? If they're short of breath, if they're leaning forward, if they're splinting, etc., they might need some help getting changed. All these little things remind them that you're speaking to a human being. All the extra points. Presentation. Now, would anyone like to present a normal respiratory examination? Has anyone written any blurbs, wants to practice? If you can do it here in front of 50 odd people, you'll be able to do it in your exam, no problem. Anybody? Yeah? Go on, have a go. Just completely normal.
So this patient is fit and well at rest. He's breathing symmetrically. There's no sort of signs of any respiratory sort of devices at the bedside. Upon examining the periphery, there's no sign of any kind of no signs of any respiratory problems. And upon examination, direct examination of the chest, there was on percussion and auscultation, the findings are normal, and expansion was also symmetrical on both sides. And there was also no signs of any sacral or peripheral edema.
Very good. Very succinct, concise. You went through everything. Went through all your steps really well. Obviously, when you write it and you've learnt it, you won't say any sort of whatever. But I put you on the spot, so really well done. So I'll read you out mine, for example. A good way, if you get stuck, just work from the hands up to the face to the neck to everything you did. Chest was had equal expansion, good air entry, normal breath sounds, resonance percussion, with no increased vocal fermentus and no peripheral edema. Those are all the steps of your exam. It's easy to present it like that when it's normal, okay? And that's the best way. When you present, hands behind your back, you face the examiner and don't look back at the patient. So, to complete your exam, we'll come on to the presentation in a second. Rule of 3. So pick 3. There's different ways of doing it. You can do bedside tests, simple tests, radiological tests. Okay, those can be your 3. So your simple tests can be peak flow, your bedside test can be like a peak flow. Yeah, because you can literally do it by the bedside. And your abdo exam like a urine dip. Alright, and a cardio test, you can do your ECG. Bedside test, simple test, like a full blood count, ureas and electrolytes, check his liver function tests as well. Okay? Like simple blood tests. Again, by the bedside, looking at any sputum pots. And then radiological tests, you can do a chest x-ray. Alright? Or a chest radiograph. Pick 3, say them, say no more. Alright? So, alternatively, you can look at the basic observations, look at his oxygen saturations and his respiratory rate trends, look at any sputum pots available by the bedside and perform peak flow, as well as getting a plain chest radiograph. Okay? Pick 3 that you're always going to say for each of your examinations and say it. Easy. So, very good. Well done. So, just an example of a normal exam. Thank you for letting me examine Mr. Smith, a 60-year-old gentleman who appeared calm and comfortable at rest. Very important in your rest examination because you're looking at the respiratory rate. With no paraphernalia of any disease around the bedside. On examination, there was no peripheral stigmata of disease in the hands, face, or chest. His heart rate was 72 beats per minute, with a respiratory rate of 16 breaths per minute. It's really important to mention your resp rate in your Resp exam. Okay? It's key. Don't forget it. On inspection of the chest, there was no obvious deformity or scarring. The chest was resonant percussion, and there was good air entry with normal vesicular breathing throughout. Furthermore, there was no sign of peripheral edema or lymphadenopathy. In summary, this was a normal respiratory examination of a 60-year-old gentleman. To complete my examination, I would. Boom, boom, boom. Easy. Alternatively, you can Rambo style it. For example, thank you for letting me examine Mr. Smith, a 60-year-old gentleman who appeared unwell in the bed on 2 litres of oxygen through nasal cannulae and a salbutamol inhaler by the bedside. His respiratory rate was 32 breaths per minute and a heart rate of 90 beats per minute. On examination, the patient showed signs of COPD as evidenced by a large barrel chest that appeared hyperinflated, indicated by displaced apex beats laterally and loss of cardiac dullness on percussion, with use of accessory muscles to breathe and splinting of his diaphragm. I also noticed a sputum pot by his bedside containing green sputum. There was reduced expansion of the chest bilaterally, because in COPD they're so hyperinflated you don't actually get that much movement, okay? But it will be bilateral. There was reduced expansion with chest was clear, because you often won't hear a lot of things on a COPD chest, but breath sounds were quiet. The chest was resonant percussion throughout. The patient also had a cushingoid appearance, indicating he may be on some steroid therapy. In summary, this is a 60-year-old gentleman with COPD that is likely to be having an infective exacerbation. To complete my examination, I would X, Y, Z. Okay? So make sure you write them, because there's common ones. The ones you're going to get in your OSCE are COPD, because they're stable, not someone who's having an infection, infective exacerbation. You might get someone who has asthma, and the only sign you'll pick up is they've got a blue inhaler by the bedside. Okay? Because normally someone who has asthma, who's not wheezy, who's not got chest tightness, they'll have a normal clear chest. And they're good people to get in your examination. You may get normal. You may get pleural effusion. That's the other big one. Okay? And then lastly, fibrosis and bronchiectasis. Again, they're stable, they've got crackles, but they're well. Okay? Think about it, in the exam you're going to get someone who's well. Okay? You're not going to get pneumonia, who's unwell. You're not going to get infective exacerbations. Alright? So, if I were you, I'd write blurbs, I'd write practice getting all the signs down in a little presentation for your each of the diseases, and then fit them in appropriately when you come to it. Okay? And because when you've learned a pattern in your head, it makes you look for them on examination. Because when you go in there, you're like, oh, I know that, he's got an inhaler, because I memorized, I'm going to say it, so he actually sees it, and it triggers it off in your head. Okay? And it triggers off your blurb in your head, and you then think, oh, okay, so he's got an inhaler, so I'm going to look for other things. Maybe he's got a nebulizer, maybe he's got any antibiotics, maybe he's got a sputum pot. And then it makes you remember other things. Okay? Well Whereas if you're just going in blindly and seeing what you pick up, you will miss stuff. Okay? Cool. Again, we do look at it every week, but hopefully we take it into account. If you wouldn't mind just taking out your smartphones, just typing in this